You are lying in bed, and it is maybe, I don't know, 11:30 p.m. on a Friday night,
Right.
and you've got the harsh glow of your smartphone just illuminating your face in the dark.
We've all been there.
Exactly. And suddenly you get this automated email notification from your healthcare provider's app, and the subject line just says, "Your lab results are ready."
Oh, yeah. That is a very specific type of modern dread, isn't it?
It really is. I mean, it's a dread that simply did not exist 20 years ago.
It didn't. The late-night patient portal drop is basically a defining feature of modern medicine now.
Because of all those health information regulations, right?
Yeah.
The ones requiring immediate patient access to electronic records.
Yeah, exactly. The clinical data is released the literal second it clears the laboratory machinery. There is zero filter.
No filter, no context.
None. And most importantly, there is no doctor sitting across from you to explain what any of the numbers actually mean.
Right, so you click the link. Because, let's be honest, human curiosity makes it completely impossible to just wait until your doctor calls on Monday morning.
You have to look. You always look.
Of course you do. So you scan down this giant spreadsheet of data. Your metabolic panels look fine. Your lipid counts are in the green. Your overall white blood cell count is totally normal.
So far, so good.
But then your eye catches a word you might not even know how to pronounce. It's bolded, and it has this bright red H for high right next to it.
Yep, the dreaded red H.
And the word is Eosinophils. So your next move is entirely predictable, right?
Oh, completely. You open a new browser tab, you type causes of high eosinophils into a search engine, and you just brace yourself.
And within about 3 seconds, you have tumbled down an absolute rabbit hole of worst-case scenarios.
It's terrifying because when you search for elevated anything in your blood, the internet algorithms seem to route you directly, almost inevitably, to one single word.
Malignancy, cancer.
Right. The search results just hit you over the head with terms like leukemia, lymphoma, myeloproliferative neoplasms.
Just massive, scary words. So welcome to this deep dive where our mission today is to basically take that late night panic and replace it with actual medical reasoning.
Which is so desperately needed.
It is. We are unpacking the silent signal of elevated eosinophil levels. Because it's wild how much psychological distress is caused by these raw, uncontextualized hematology reports.
It's staggering, really. And look, knowledge is power, right? Patients absolutely should have access to their own biological data.
For sure.
But in the study of blood, context essentially dictates reality. A number on a page, when you view it in total isolation, can be actively misleading.
Because an algorithm is just scraping medical literature, right?
Exactly. It scrapes the literature to tell you what an elevated cell count means, but it completely strips away the nuance of clinical probability.
Well, we are going to dismantle those misunderstandings today. We want to explain to you exactly how clinicians actually evaluate this specific biological signal.
It's a fascinating process.
It is. But before we can understand why an elevated level does not automatically mean a malignancy, we really have to establish what these cells actually are.
We have to start with the basics.
Right. We need to look at the human immune system, specifically the white blood cells, and figure out the eosinophils' actual day job.
So the human immune system is basically a highly differentiated military force.
Okay.
If you look at a complete blood count, or a CBC, you see the red blood cells carrying oxygen, the platelets managing the clotting, and then the white blood cells handling defense.
The Defense Department.
Right. But those white blood cells, they are not just one big monolith. You have neutrophils, lymphocytes, monocytes, basophils, and eosinophils.
That's a lot of different units.
It is. Now, the neutrophils are like your everyday beat cops. They're by far the most abundant.
So they're the ones responding to, like, everyday stuff.
Exactly. If you get a paper cut or just a typical bacterial sinus infection, the neutrophils flood the area. They handle routine trauma and very common pathogens.
Got it. So where do eosinophils fit into this?
Eosinophils, by contrast, make up a tiny, tiny fraction of that circulating force.
Like how tiny?
Under normal conditions, they account for less than 5% of your total white blood cells.
Oh, wow. So very small.
Very small. They are produced deep inside your bone marrow from myeloid stem cells. They enter the bloodstream, and they essentially just patrol the perimeter.
Just waiting around.
Right. But they do not just spontaneously multiply for no reason.
Okay, so when their levels do rise above that normal threshold, which is clinically known as eosinophilia, right?
Yes, eosinophilia.
So when that happens, they are responding to a highly specific targeted trigger.
Exactly. Their biology actually tells the story of their function. If we look at the history of their discovery, It provides this massive clue to how they operate.
Oh, I love the history part. When was this?
Back in 1879, there was this scientist named Paul Ehrlich, and he was experimenting with different chemical dyes to stain blood smears.
So he could actually see the different cells under a microscope.
Exactly. Most cells are basically transparent, so you have to dye them. He used this highly acidic, reddish-pink dye called eosin.
Wait, named after Eos, the Greek goddess of the dawn.
You got it.
Huh?
Because of that bright pink dawn-like color.
That's amazing.
So Ehrlich noticed that a very small percentage of white blood cells contain these large granular structures in their cytoplasm that aggressively absorbed this pink dye.
Like little pink polka dots inside the cell.
Pretty much. And he literally named them eosinophils, which just means eosin-loving.
That makes perfect sense. So those granules, the pink polka dots, they are the key to everything, right?
They are the entire point of the cell.
So if the overall white blood cell count is the total police and military force of a city, the eosinophils are basically the hazmat team.
That is a perfect analogy.
Right, because the granules Ehrlich saw absorbing that pink dye, they aren't just, structural anomalies. They are payload packages.
Oh, they absolutely are. The hazmat analogy holds up remarkably well when you actually look at the biochemistry.
What's inside the packages?
Well, the granules inside an eosinophil contain highly potent, specialized chemical weapons.
Weapons. Okay, so not just regular immune stuff.
No, we are talking about major basic protein, or MBP. We're talking about eosinophil peroxidase, eosinophil cationic protein, and eosinophil-derived neurotoxin.
Neurotoxin. From our own immune system.
Yes. These are exceptionally destructive, toxic proteins.
Wow.
The body deliberately keeps the numbers of these cells low because you really do not want these chemicals circulating freely all the time.
I assume because they're dangerous to our own bodies, too.
Exactly. They are highly destructive to surrounding healthy tissue if they just deploy randomly.
So if I'm walking down the street, right, and I see a couple of beat cops standing on a corner, I just assume someone ran a red light or maybe there's a parade.
Sure, nothing crazy.
But if I turn the corner and see the actual hazmat team, like people in full yellow biosafety suits with oxygen tanks deployed outside a building, I know a very specific chemical reaction or a highly specialized cleanup is happening.
Right. You know it's serious, but specific.
Right. The presence of the hazmat team outside a building does not mean the building itself is randomly collapsing or that a bomb is going off. It just means a specific protocol has been triggered.
That's exactly it. So seeing eosinophilia on a lab report should really prompt the question of what specific chemical spill the immune system is trying to clean up.
It shouldn't prompt an immediate assumption of structural failure, like a cancer of the bone marrow.
No, not at all. The process of deploying these cells is highly, highly regulated.
How does the body call them in?
The body uses a very specific signaling molecule. It's a cytokine called interleukin-5, or just IL-5.
IL-5. Okay, so that's the radio call for the hazmat team.
Exactly. When a specific threat is detected in the tissue, the immune system releases IL-5. It travels straight to the bone marrow and signals the stem cells.
And it tells them to accelerate the maturation of eosinophils and release them into the bloodstream.
Yep, it pumps them out. But then those cells have to actually find the problem. They do not just float aimlessly.
Right, they need an address.
So they use a process called chemotaxis. They're essentially following a chemical scent trail through the bloodstream.
Like a bloodhound.
Very much like that. And then they squeeze through the walls of the blood vessels, which is a process called diapedesis, and they physically enter the specific tissue where the threat is located.
And once they finally arrive at the scene, they unleash those pink staining granules.
They degranulate, they drop the payload.
So if they're the hazmat team and they're deploying major basic protein and literal neurotoxins, we really need to define the threats they're actually fighting.
We do. We need to look at the usual suspects.
Let's do that. Let's move into the usual suspects. If it is almost never the worst-case scenario that the internet suggests, what triggers that IL-5 alarm in everyday life?
Well, clinicians basically categorized the vast majority of real-world eosinophilia cases into 4 main buckets.
4 buckets. Okay, what's the first one?
The first, and overwhelmingly the most prevalent in industrialized nations, is allergic disease.
Allergies. Like we're talking about seasonal hay fever, eczema, and asthma.
That's the one.
See, that seems entirely disproportionate to me. Like, why would the immune system deploy its most toxic, heavily armed hazmat team to deal with oak pollen or pet dander?
Oh, it is totally disproportionate. But allergies are, by definition, a hypersensitivity reaction.
So the body's just
A
overreacting.
massive overreaction. The immune system is misidentifying a completely harmless, inert environmental protein as a highly dangerous pathogen.
Okay.
So the body mounts what is called a type 2 or Th2 inflammatory response.
A Th2 response.
Right. The immune cells in the lining of your respiratory tract or your skin, they encounter this pollen, they absolutely panic, and they release IL-5.
And then the bone marrow dutifully pumps out the eosinophils, which migrate straight to the nasal passages or the lungs.
Exactly. And once they get to the lungs, in the case of asthma, for example, they do what they are programmed to do.
They drop the bombs.
They degranulate. They release the major basic protein and the eosinophil peroxidase all over your airway tissue.
Wow. Which explains why chronic asthma is so damaging to the respiratory tract over time.
Yes. The eosinophils are carpet bombing the airways to destroy what they think is a threat, the pollen. But those toxic proteins strip away the healthy epithelial cells lining your lungs.
That sounds incredibly painful for the tissue.
It is. They cause airway hyperresponsiveness, severe swelling, and tons of mucus production.
And over time, doesn't this lead to permanent changes?
It does. It leads to airway remodeling, where the structural tissue of the lungs becomes permanently thickened and scarred from all the chemical burns, essentially.
So if I understand this right, you could literally go get a routine physical in the middle of spring while the trees are blooming out.
Yep.
Have a totally mild, maybe untreated asthma flare-up or just severe hay fever, and your blood work comes back with a bright red H next to your eosinophil count.
Happens all the time. Every single spring.
The number on the page is flagged as abnormal, but biologically, your body is executing its exact programming perfectly.
The mechanism is working flawlessly. The targeting system is just aimed at the wrong thing.
It's aiming at a ghost.
Pretty much. Which brings us to the second major category. And this one actually explains why that targeting system exists in the first place.
Right, because if eosinophils were just an evolutionary mistake that only caused asthma and allergies, natural selection would have likely phased them out millions of years ago.
Exactly. Biology doesn't keep a wildly destructive cell around just to give you a runny nose. They have a very specific, crucial target.
And what is that?
Parasitic infections. Specifically, helminths, which are parasitic worms.
Worms. Okay, this is where the physical scale of the immune response becomes completely fascinating to me.
The scale is the whole secret.
Because the everyday beat cops, the neutrophils, and those other cells called macrophages, they fight bacterial infections through phagocytosis, right?
Yes. Phagocytosis.
Yeah.
They literally just engulf the bacteria and digest it internally.
Like Pac-Man.
Very much like Pac-Man. But a bacterium is tiny. A single macrophage can swallow it whole with no problem.
But a parasitic worm, like a hookworm or a schistosome, is massive on a cellular scale.
It's gigantic. It can be millimeters or even centimeters long.
So a single microscopic white blood cell obviously cannot swallow a worm.
No, it's like a person trying to swallow a freight train.
Right. So this physical mismatch is why the eosinophil evolved its unique weaponry.
Exactly. When a parasitic worm enters the body, let's say a hookworm larva penetrating the skin of a bare foot.
Which sounds awful.
It is. It migrates through the bloodstream to the lungs, gets coughed up, and then swallowed to reside in the intestines.
What a journey. So what does the immune system do?
The immune system coats the outer surface of that worm with specific antibodies, usually immunoglobulin E or just IgE.
Okay, so IgE is like painting a target on the worm.
Precisely. And the eosinophils have specific receptors that recognize those IgE antibodies.
So they swarm it.
They swarm the worm, they bind directly to the antibodies on its surface, and then they unleash the payload all at once.
A coordinated strike. What's the clinical term for that?
It's a process called antibody-dependent cell-mediated cytotoxicity.
Wow. So they surround this macroscopic invader and degranulate it. And what happens to the worm?
Well, the major basic protein literally melts the cellular wall of the parasite.
It melts it.
Yeah, and the eosinophil-derived neurotoxin attacks the parasite's nervous system. They completely destroy the threat from the outside in.
That is incredibly metal.
It really is. But here's the catch. In heavily industrialized countries with modern sanitation, parasitic infections are relatively rare.
Right. We aren't dealing with hookworms on a daily basis.
We aren't, which leaves this highly specialized hazmat team without a clear, natural target.
And this brings us directly to the hygiene hypothesis, doesn't it?
It sure does.
Because the idea is that our immune systems evolved over millions of years to fight off a constant, unending barrage of parasites.
Oh, we evolved alongside them.
So these cellular pathways expect to be utilized. And in the modern ultra-sanitized world, the eosinophils are essentially bored.
Extremely bored. The Th2 immune pathways lack their natural parasitic targets, so they become hyper-reactive to harmless environmental proteins.
Like the pollen or peanuts or dust mites we talked about earlier.
Exactly. The allergic response is just the anti-parasitic response firing at a ghost.
That evolutionary perspective perfectly bridges those first two categories.
It does, and it guides the doctor.
Yeah.
If a patient recently returned from, say, a backpacking trip through a tropical region, or waded through freshwater rivers, or ate undercooked wild game
and presents with a high eosinophil count,
then a clinician will actively investigate for parasites first.
But if the patient hasn't traveled anywhere and has a history of wheezing and severe eczema, then the allergic pathway is just the most logical deduction.
Exactly. It's about context.
Okay, so that's two buckets. Allergies and parasites.
Yeah.
What is the third bucket of usual suspects?
The third bucket involves situations where the immune system's targeting goes beyond environmental allergies and actually begins attacking the body itself.
Oh, autoimmune issues.
Autoimmune and inflammatory diseases, yes. In these conditions, the immune system loses its self-tolerance.
So it begins directing the hazmat team to healthy native tissue.
Right. A primary example is eosinophilic granulomatosis with cholangitis.
That is a mouthful.
It is. It was formerly known as Churg-Strauss syndrome. It's a rare type of vasculitis where the immune system causes massive eosinophilic infiltration into the walls of your small and medium blood vessels.
Into the blood vessels themselves. But if the blood vessels are inflamed and just flooded with those toxic granules, doesn't the blood flow to critical organs get compromised?
It absolutely does. It could lead to severe neuropathy, where the actual nerves die off from lack of blood flow, or even severe cardiac and renal issues.
That sounds terrifying. Are there other conditions in this bucket?
Yes, another increasingly common inflammatory condition here is eosinophilic esophagitis, or EoE.
EoE. I've been hearing more about that lately. What is it?
Well, the immune system mounts a localized allergic response right in the lining of the esophagus, usually triggered by specific food antigens.
So the esophagus basically becomes packed with eosinophils.
Yes. The tissue swells up significantly, and patients who are often young adults or even children present with dysphagia.
Meaning they literally cannot swallow their food properly.
Right. Or food actually gets impacted, literally stuck in the throat.
Oh, that's so scary, especially for a kid.
It is. But again, it's the hazmat team acting inappropriately.
Okay, so that's three. Allergies, parasites, autoimmune. Now, the fourth category, and I think this one is perhaps the most clinically deceptive and really the most relevant to that late-night panic over a lab result.
I agree completely. We have to discuss medication reaction.
Right, because a prescribed, seemingly benign drug can trigger an immune response that causes a massive spike in this specific white blood cell count.
The clinical term is drug-induced eosinophilia, and it is incredibly, incredibly prevalent.
I mean, the complexities of modern pharmacology mean patients are exposed to really complex molecules daily.
Every single day. And the immune system can tag a medication as a foreign invader and mount a huge hypersensitivity reaction.
But the timeline of these reactions is what makes them incredibly difficult to diagnose, right?
That's the trickiest part.
Because we are not talking about taking a pill and immediately breaking out in hives an hour later. The type of reaction that drives up the eosinophil count can be delayed by weeks.
Exactly. That delay is the hallmark of conditions like DRESS syndrome.
DRESS syndrome, what does that stand for?
It stands for drug reaction with eosinophilia and systemic symptoms.
Okay, so walk me through how that actually looks for a patient.
So a patient might start a new medication. Commonly, it's certain antibiotics like penicillins or cephalosporins, maybe anticonvulsants for seizures, or medications like allopurinol for gout.
Pretty common thing.
Very common. So they take the drug for 3, maybe 4 weeks with absolutely no issues.
Nothing.
Nothing. Then suddenly they develop a widespread rash, a high fever, their lymph nodes swell up, and their liver enzymes spike.
And if you draw their blood right then.
Their eosinophil count is astronomically high.
But here's the crazy part. By the time the reaction peaks, the patient might have actually finished the entire course of the drug that caused it.
Often, yes. They go to the doctor, they get the blood work, they see the high eosinophils, and they assume their internal organs are failing from some primary new disease.
Completely unaware that their immune system is basically fighting a phantom war against the antibiotic they finished a whole month ago.
Exactly. And sometimes the reaction is completely subclinical.
Meaning what? No symptoms at all.
Right. There's no fever, no rash, no liver involvement.
Ah.
The only sign that the body has mounted an immune response to the medication is the silent signal of the elevated eosinophil count on a routine metabolic panel.
Just a number on a page. So how does a clinician look at a raw number on a spreadsheet, say, an absolute eosinophil count of 1,200, and actually differentiate between a delayed hypersensitivity to ibuprofen, a mild case of asthma, or a parasitic infection?
It's tough because the number itself does not carry a barcode identifying the trigger.
Right. The lab report just says 1,200. It doesn't say 1,200 because of pollen.
Exactly. The raw lab data is simply a siren. It indicates that the IL-5 pathway has been activated and the bone marrow is responding.
So the physician has to essentially perform the investigative work to locate the fire.
They do. And the complexity of modern life, the polypharmacy, where patients take 5 different medications daily, the global travel exposing us to novel pathogens, the rising rates of adult-onset allergies, it ensures that these reactive spikes in eosinophils are incredibly common.
Okay, so we have firmly established the biological reality here. The hazmat team is deployed for mundane, everyday reasons: pollen, bored immune pathways, confused autoimmune responses, and routine pharmaceuticals.
The usual suspects.
We know the mechanisms, so why does the internet immediately suggest malignancy? If these are by far the most common causes, why is the general public terrified that this specific lab result means cancer?
Because fear drives clicks.
Let's deconstruct the cancer myth right now and answer the question directly. What specific level of eosinophils definitively indicates a malignancy?
Zero.
Zero.
There's no specific level, no threshold, and no mathematical cutoff of eosinophils that definitively indicates cancer.
That is so important to hear.
Eosinophil elevation must never be viewed, presented, or interpreted as a primary diagnostic marker for malignancy.
Because a search algorithm does not care about clinical probability.
It really doesn't. It prioritizes rare, severe outcomes because they generate case reports in medical journals and they drive user engagement.
The internet totally lacks the foundational concept of a differential diagnosis.
It just gives you the worst case scenario.
However, to provide a totally complete scientific picture, we do have to examine the rare associations where malignancy and eosinophilia actually do overlap and explain exactly the mechanisms involved.
We do. And the association generally occurs through 2 distinct biological pathways.
Okay, what's the first one?
The first is through what we call a paraneoplastic syndrome.
Paraneoplastic.
Right. This occurs when a patient has a primary solid tumor, like a carcinoma of the lung, colon, or stomach, or maybe a specific type of lymphoma, like Hodgkin lymphoma.
Okay.
The tumor cells, through their unchecked, mutated growth, begin to aberrantly secrete cytokines.
Wait, they secrete the siren. They start pumping out interleukin-5.
Exactly. The tumor accidentally manufactures the exact chemical signal that the immune system uses to call for the hazmat team.
Oh, wow. So the IL-5 travels through the bloodstream to the bone marrow.
Yep.
And the bone marrow, operating perfectly normally, reads the signal and just mass produces eosinophils.
It's just doing its job.
So the eosinophils in this scenario are not malignant at all.
Not at all. They are completely healthy, normal cells. They are just innocent responders being tricked by a fraudulent chemical signal released by the actual tumor somewhere else in the body.
That is fascinating. So the analogy here is basically trying to deduce if a house fire was caused by intentional arson just by looking at the color of the smoke billowing out of the windows.
I love that analogy. It's perfect. The smoke tells you there is combustion. It tells you the fire department is necessary.
But the smoke tells you absolutely nothing about the underlying motive or origin.
Nothing. It does not tell you if someone poured gasoline on the floorboards or if a 50-year-old wire just short-circuited in the wall.
The reaction is just a reaction.
Exactly. In a paraneoplastic syndrome, the eosinophilia is just the smoke. The tumor is the arsonist.
Got it. Okay, so what is the second pathway?
The second pathway involves the bone marrow itself. This involves a category of diseases called myeloid neoplasms.
Myeloid neoplasms. So
Right.
these are primary blood cancers.
Yes, where the genetic mutation actually occurs inside the stem cell in the bone marrow that is responsible for producing the eosinophils.
So the stem cell acquires a genetic error, and it begins to basically clone itself uncontrollably, churning out massive quantities of malformed, malignant eosinophils.
Exactly. And the distinction here is absolutely crucial.
How so?
Well, in allergies, parasites, and even paraneoplastic syndromes, the expansion of cells is polyclonal.
Polyclonal? Meaning what?
Meaning the bone marrow is reacting to an external signal and producing a diverse, healthy army of cells from many different lineages.
Okay, so it's a normal response to an abnormal situation.
Right. But in a myeloid neoplasm, the expansion is monoclonal.
Mono meaning one.
Exactly. A single mutated cell is endlessly copying itself without any external signal from IL-5 whatsoever.
It's just broken hardware.
Precisely. And one of the most famous, albeit incredibly rare, examples of this is a mutation involving a fusion gene called FIP1L1-PDGFRA.
Wow. FIP1L1-PDGFRA.
Don't worry, there's no test later.
Yeah.
But basically, a piece of genetic code breaks and fuses with another piece, creating a constantly activated signaling protein that literally forces the eosinophils to multiply endlessly.
But this condition, this type of idiopathic hypereosinophilic syndrome, is extraordinarily rare, isn't it?
Extraordinarily, we are talking about fractions of a percent of all hematological cases.
Yet, because the genetic mechanism is so well documented and I assume uniquely treatable.
Oh, very treatable with targeted therapies like imatinib.
Right, so because of that, it features heavily in medical literature, which those search algorithms just happily scrape up and present to a patient with seasonal asthma as a likely outcome.
It's a huge flaw in how we consume medical data online.
We really have to draw a hard line between a reactive cell and an actual tumor marker.
Absolutely.
Because when oncologists look for cancer, they look for specific proteins produced exclusively by the mutated cells, right? Like prostate-specific antigen, or PSA for prostate cancer, or CA-125 for ovarian cancer.
Exactly. Those are calling cards left at the scene by the actual criminal.
But the eosinophil is not a calling card. It is the police officer responding to the radio call. You do not blame the first responder for the crime.
You never blame the responder. And if the presence of the responder does not identify the crime, the clinician has to pivot from reading the lab report to evaluating the actual patient.
Which brings us to the real-world application. The clinical evaluation of an abnormal eosinophil count is basically a masterclass in deductive reasoning.
It is. It relies so heavily on the art of medical history taking.
So when that panicked patient sits down in the clinic on Monday morning, the physician does not just start by ordering bone marrow biopsies or full-body CT scans.
Oh, definitely not. They start with a rigorous interrogation of the patient's entire life over the preceding months.
Because the history dictates the testing.
Always.
Yeah.
The physician will probe the travel history meticulously. Have you been outside the country in the last 2 years?
Right. Did you swim in any freshwater lakes in regions endemic for schistosomiasis?
Did you walk barefoot on soil in areas known for hookworm? Did you consume any uninspected or undercooked meat, like bear or boar, which can transmit trichinella?
Just really specific lifestyle questions, and that covers the parasitic angle.
It does. Then the focus shifts to the respiratory and dermatological systems.
Like, have you had any new wheezing, shortness of breath, or chronic coughing?
Exactly. Any mysterious rashes, hives, or severe eczema flares? Any trouble swallowing your food?
Which covers the allergic and autoimmune buckets we talked about.
Right. And then, honestly, the most rigorous part of the history, the medication timeline.
Oh man, the physician has to perform a full reconciliation of every single substance the patient has ingested.
Every single one. Not just new prescriptions, but every over-the-counter painkiller, every random herbal supplement, every topical cream, and every antibiotic taken in the last 8 to 12 weeks.
Because the delayed nature of drug hypersensitivity means the trigger is often buried a month in the past.
It's serious detective work.
Now, while the physician is gathering this narrative context, they also have to perform a mathematical evaluation of the blood work itself, right?
Yes, the math is crucial because the raw percentage of eosinophils listed on a standard CBC is not clinically sufficient.
Why not?
Because the percentage is relative. It can fluctuate wildly based on the levels of other white blood cells.
Oh, I see. So the doctor has to calculate the absolute eosinophil count, or the AEC.
Exactly.
How do they calculate that?
To get the absolute count, you take the total white blood cell count and multiply it by the percentage of eosinophils.
Okay, so if your total white blood cell count is 10,000 cells per microliter, and your eosinophils are sitting at 10% mobile.
Then your AEC is 1,000 cells per microliter.
Got it. And the medical community uses specific thresholds to categorize the severity of that absolute number, right?
Yes. A normal count is generally anywhere from 0 to about 500 cells per microliter.
Okay. And then mild eosinophilia.
Mild is classified as 500 to 1,500 cells.
Moderate.
Moderate is 1,500 to 5,000 cells.
And severe.
Severe eosinophilia, which is also known as hypereosinophilia, is anything above 5,000 cells per microliter.
Okay, so the magnitude of the elevation really guides the urgency of the investigation.
It absolutely does. If a patient presents with an AEC of 800, such as a mild elevation, and they have a documented history of allergic rhinitis, and the blood was drawn in May during peak pollen season.
The clinical mystery is effectively solved right there.
Pretty much. The physician treats the allergy symptoms, reassures the patient, and repeats the CBC in a few months to ensure the numbers have stabilized.
But the clinical algorithm shifts entirely depending on magnitude, duration, and the presence of systemic symptoms.
It does.
At what point does a clinician decide that the asthma inhaler or the discontinued antibiotic just does not fully explain the picture?
Well, the threshold for deeper investigation relies on three intersecting factors.
Okay, what's the first?
First is the magnitude. If the AEC is severe, pushing above 5,000 or 10,000 cells per microliter, the physician must act aggressively, regardless of the suspected cause.
Because having that many activated eosinophils circulating in the bloodstream poses an immediate physical threat due to eosinophil-mediated tissue damage.
Exactly.
Because the hazmat team is essentially overpopulated, extremely bored, and starting to spray their toxic granules indiscriminately everywhere.
Yes. When the levels are that high, the eosinophils can infiltrate the vital organs. The most critical risk is eosinophilic myocarditis.
Where the cells infiltrate the heart muscle.
Yes. And the major basic protein begins to literally melt the cardiac tissue.
Oh my God.
It can cause acute heart failure, which is a condition historically referred to as Loeffler's endocarditis.
So to prevent irreversible organ damage, the physician might initiate high-dose corticosteroids immediately, right? Just to kill off the excess eosinophils before even confirming the underlying cause.
They have to. It's a medical emergency.
Okay, so magnitude is factor one. What's the second factor?
The second factor is duration.
So how long they stay high?
Right. If the count is moderately elevated, say 2,000 cells, but it remains persistently high for 6 consecutive months, despite treating suspected allergies and removing all potential offending medications.
Then the persistence itself becomes a major red flag.
Exactly. It means the immune system is locked in an activated state, and the primary trigger has simply not been identified yet.
Okay, and the third factor?
The most crucial determining factor is the presence of systemic B symptoms.
B symptom.
Yes. If a patient presents with elevated eosinophils, accompanied by unexplained, rapid weight loss, severe drenching night sweats, or a persistent fever that cannot be attributed to a clear infection, the clinical picture fundamentally changes.
Because these are systemic inflammatory alarms.
Right. When the magnitude is extreme, the duration is prolonged, and the systemic alarms are ringing, the investigation has to move beyond the standard clinic visit.
So the diagnostic pathway becomes highly specialized.
It does. The primary care physician will refer the patient to a hematologist or an allergist immunologist.
What do they do next?
They will order peripheral blood smears to look at the physical architecture of the eosinophils under a microscope.
They actually look at the cells themselves.
Yes. They are looking to see, are the cells structurally mature and healthy, indicating a reactive process? Or do they look dysplastic and mutated?
Right, and they will run specialized serology panels to test for really obscure parasitic antibodies, I assume.
They will.
Yeah.
They might even order echocardiograms and check troponin levels to ensure the heart muscle is not under attack like we talked about.
And only after exhausting all of those steps, after systematically evaluating the allergic, infectious, and pharmacological possibilities, does the investigation cross the threshold into actual oncology.
That is the absolute final step, a bone marrow biopsy, where a needle is inserted into the hip bone to extract the marrow for genetic sequencing, or full-body imaging to look for occult solid tumors. Those are the absolute last steps in the algorithm.
Because this approach represents a foundational tenet of medical ethics and clinical philosophy, doesn't it?
It really does. Rule out the horses before looking for zebras.
I love that phrase. When you hear hoofbeats, assume it is a horse, a common mundane ailment. Do not assume it is a zebra, a rare exotic disease, until you have proven there are absolutely no horses around.
Exactly. Because subjecting a patient to an extensive oncology workup carries significant inherent risks.
Oh, huge risks. A bone marrow biopsy is a highly invasive, painful procedure with real risks of infection and bleeding.
And CT scans expose the patient to massive doses of ionizing radiation.
And more importantly, initiating these tests based purely on an isolated blood count inflicts massive, often unjustified psychological trauma on the patient.
It's devastating. And this is exactly why the direct-to-consumer model of instant lab results fundamentally subverts the horses before zebras philosophy for the patient.
Because the patient receives the raw data in a total vacuum.
Right. They enter the data into a search engine, which completely bypasses the horses and exclusively shows them the zebras.
It skips the logic of probability entirely.
It does. The physician's role is not just reading the data. It is contextualizing the data within the complex, multidimensional ecosystem of human biology.
Because a CBC is merely a snapshot of the cellular environment at a specific millisecond in time, it is a piece of evidence, not a destiny.
Well said.
The biological reality of the eosinophil is truly a masterclass in evolutionary specialization. To synthesize the takeaways from this deep dive, if you are staring at that patient portal right now, you need to reframe your entire understanding of the immune system.
You really do. Eosinophils are a highly specific tactical unit. They are the hazmat team.
In the vast majority of clinical scenarios, their deployment is a perfectly healthy, functional reaction to completely mundane environmental factors.
They're fighting the pollen from the oak tree outside your window. They're confused by the antibiotic you took for a sinus infection last month. Or they are just executing archaic anti-parasitic programming in a very sanitized world.
An elevated absolute eosinophil count is a silent signal that definitely demands evaluation. It requires your physician to play detective, to map your recent history, and to mathematically analyze your blood work.
Yes, but it is unequivocally, definitively not a standalone diagnostic marker for cancer.
When you see that red H, recognize that your immune system is simply communicating. It is functioning exactly as it evolved to function.
Your responsibility is not to diagnose the chemical spill based on a panicked internet search. Your responsibility is to take that report to your physician, who actually possesses the clinical methodology to translate that cellular communication safely and logically.
You do not need to fall victim to the information overload of the modern patient portal. You now possess the biological context to understand what that single data point actually represents.
Context is everything.
It really is. But before we conclude today, there is a fascinating forward-looking concept regarding how we analyze these cells.
Oh, the future tech.
Yeah. Right now, clinical medicine relies heavily on inductive reasoning. We look at the absolute eosinophil count, we see that the hazmat team has been deployed, and then we have to meticulously trace the patient's history to deduce exactly why they are there.
Right. We count the cells, but we cannot actually interrogate them directly.
Exactly. But the fields of transcriptomics and single-cell RNA sequencing are advancing so rapidly. What if, in the very near future, medical technology could look beyond the sheer volume of the cells and actually read their internal chemical logs?
That would change everything.
What if a routine blood draw allowed a machine to sequence the messenger RNA inside the individual eosinophil, revealing the exact specific receptor that triggered its deployment?
So instead of just knowing the hazmat team is active, the blood test could tell the physician definitively that the cells are currently engaged in a Th2 response against a specific peanut protein.
Or reacting to a unique penicillin molecule.
Or targeting a specific parasitic antigen.
Exactly. How would the ability to read the literal chemical memory of a single white blood cell completely eliminate the guesswork, the anxiety, and the prolonged detective work from the diagnostic process entirely?
It would be revolutionary.
It's definitely something to think about the next time you provide a routine blood sample. Thanks for joining us on this deep dive.